So my myth I'm hoping to bust today is rapid response teams improve in-hospital mortality rates. So this slide is mainly addressed to the residents of the group, but this is a question I hear all the time, mainly in the MICU workroom. Should I go to that rapid response? So as an intern, I'll never forget, I had one senior that insisted we attend every single rapid response. I had other seniors who, they said, yeah, let's walk by, but it was kind of conditional, and others who said ignore it completely. I'll never forget asking this question to Dr. Freed during ICU rounds, because he just looked at me and said, no. And today I get to explain to you guys why he said no. So quick overview, we're going to go through the background and the development of rapid response teams, what they are. We're going to review some early trials and then spend a good bit of time going over some meta-analyses and then a summary. So rapid response teams were developed to prevent serious hospital events. There was a study published by the U.S. Committee on Quality and Safety in Hospitals in 2000 called To Err is Human. And in that study, they estimated that 98,000 people die annually from medical error. And they asked the questions, how can we improve and how do these events happen? This led to a lot of work looking into what's changing with the patient as they're clinically deteriorating. These terms are from a New England Journal of Medicine review article on rapid responses, and they coined this term failure to rescue, which is failure to recognize changes in a patient's condition until a major complication, such as even death, have occurred. And there's a progression to this. Initially, there are warning signs, mainly changes in vital signs, changes in mentation, changes in urine output. There's a failure to monitor. I know sometimes on our wards, vitals are only checked every 8 hours. Nurses can have a high census. They're not in the patient room every time. And we as physicians sometimes only see the patients, I think most times we only see the patients once a day. And then there's sometimes a failure to escalate. The nurses don't necessarily recognize the importance of that vital sign and getting more help. And then sometimes when they do, there's a progression that has to happen. The nurse has to talk to the intern has to talk to the senior, and a lot of academic centers, they have to talk to the fellow and then the attending before anything can happen. So rapid response teams were designed to circumvent that process and get nurses the support they needed right away. So this is a table, again, from that NEJN review article comparing and contrasting code teams versus rapid response teams. The criteria is different. Code teams, the patient's pulse lists. In rapid response teams, it can just be changes in vital signs, changes in just their general condition. And then the composition of rapid response team changes. So rapid response teams were actually developed in Australia. In Australia, a rapid response team includes an ICU fellow. There's medical emergency teams and critical care outreach. Critical outreach is more the European name. And those teams all actually include a physician at every single activation. In the United States, we have our rapid response teams, which are primarily ICU nurse and a respiratory therapist. Generally, a physician's not required to attend. The criteria for calling, this is a table from one of the first studies that looked at rapid response teams. Like I've already mentioned a couple times, changes in vital signs, change in consciousness. A staff member could just be worried about the patient. The table to the left just shows the most common triggers for calls. Usually a nurse is concerned or there's a change in respiratory status. This is actually our policy here at Cottage Health. You can see the criteria for calling is a lot more expansive. The patient could have chest pain, new onset seizures, pain that's unrelieved, worse, new, or different. And the idea is they wanted to give nursing maximum support so nurses can call essentially about anything they're worried about. So this was one of the first studies looking at the implementation of rapid response teams and their outcomes. This was done in Australia by Belemo and his group, and it's a prospective before and after trial. So what they did is they have a cohort without intervention for 4 months, then they had an implementation period, and then a 4-month period where they started a rapid response team and generated that. The outcomes they looked at were number of cardiac arrests, patients dying after cardiac arrest, post-arrest bed days, and the overall number of hospital deaths. As you can see from this table, their results were really impressive. Before versus after period, there were 63 versus 22 cardiac deaths, 302 versus 222 deaths, and then 37 versus 16 deaths attributed to cardiac arrests. So this paper generated a lot of shockwaves as to rapid response teams seem to be a really good thing to implement in hospitals. However, it was a single center, it was non-blinded, there was no contemporaneous control, and so a lot of people argued that a lot of the changes you see in the after group could have just been seasonal variation in combination with the MET team activation. This was another before and after study done around that time. Same kind of model where you have a period of before and a period of after. I thought it was interesting, this one was pretty interrupted. The before period was 1996 and the after period was in 1999. They looked at incidence and outcome of unexpected cardiac arrest, and again they had some really impressive numbers. Mortality after cardiac arrest went from 77% to 55% after implementation of rapid response team, and then overall hospital mortality decreased from 19% to 17% per 1,000 hospital admission. But these were single center before and after prospective trials, and there were a lot of criticism that this was pretty low evidence, even though the numbers were very impressive. So this is the first randomized control trial, also done again by Belemo and his group, who actually developed and are big advocates for the rapid response teams. And this was I think a very well done trial. What they did is they took 23 hospitals in Australia and they randomized them to either implementation of a MET team or no intervention. And they looked at a composite outcome of cardiac arrest, unexpected death, or unplanned ICU admission. And very interestingly, they found that there was no significant change in that primary outcome. And even in their subgroup analysis, they found that there was actually no change in hospital mortality after implementation of a rapid response team. So their conclusion was that it doesn't substantially affect unexpected death rates. Despite the publication of that RCT, rapid response teams had already caught on like wildfire. In 2004, they were the 100 Lives campaign recommended that hospitals implement a rapid response team. 2008, we actually started our rapid response team. 2009, the Joint Commission, one of their safety goals, actually suggested implementing a rapid response team. National Institute of Clinical Excellence recommended implementation. And by the late 2000s, most hospitals were either required or under strong pressure to implement a rapid response team, despite that most of the evidence had been from before and after prospective trials with no contemporaneous control. And the one RCT showed that there was no significant change. So then we get to our meta-analyses. This is the first one I could find published in JAMA. It's a literature review over a long period of time, and they looked at 18 studies. Of these 18 studies, only 6 were deemed to be, quote, high-quality evidence. 2 randomized control trials, 2 observational trials with contemporaneous controls, and then 2 observational trials with adjustments for pre-intervention trends. Their outcome, they looked at hospital mortality, and they found that there was significant heterogeneity in results. And I kind of listed it out. But you can see 2 studies did show a significant reduction, but then 1 study showed increased mortality. The results were kind of all over the board. So overall, implementation of rapid response teams was not associated with lower hospital mortality rates. We're going to look at a lot of forest plots today. This is from their study. You can see the adult studies are at the top and then pediatric studies are at the bottom. You can see these studies, there's a lot of variation around that relative risk of 1. And then I thought it was interesting, pediatric studies, it looks more consistent that there is a reduction in mortality. Their other endpoint, they found that there is a 33.8% reduction in rate of non-ICU treated cardiopulmonary arrests. And then on further discussion, they talked about how the effect of RET implementation on hospital mortality had shifted towards the null over the past decade, which would suggest a possible publication bias. And they also thought that the lack of change in mortality could be because the short-term impact of RRTs on cardiac arrest might not be sufficient to alter the overall survival in these severely ill patients. And I felt that that was further supported by the fact that implementation of RRTs in the pediatric population was associated with lower hospital mortality rates. The kids could bounce back. This was another meta-analysis in Annals. They took the data from that last meta-analysis that we looked at and added 26 studies to it. And they found, on pulling all of that data, that there was a reduction in mortality and cardiopulmonary arrest outside of the ICU. But in their discussion and looking at the data, none of the 26 studies used randomization or had a concurrent control group, and only 2 studies were actually multiple studies. So they do note that all of this evidence since 2008, since that meta-analysis, had been low to moderate quality studies, and several with inconsistent findings. There was still heterogeneity within the results. This is their forest plot. And you can see there's smaller study sizes. A lot of these studies are actually statistically insignificant. And it just even looking at this forest plot, it doesn't look very convincing. Then this is the final meta-analysis I'll talk about from Critical Care Medicine in 2015. So they looked at 29 studies from 1990 to 2013. They had only 5, I meant to say high-quality studies, they weren't all RCTs, and then 24 of these before and after studies without contemporaneous control. And then their data analysis was different than the others I had looked at. They performed what's called a meta-regression of the data to better assess heterogeneity within study design. Their results, they also found an overall reduction in hospital mortality with a rate of 0.87, but they did acknowledge this heterogeneity in results. Cardiopulmonary arrest, they also found a reduction, more substantial, but again with substantial heterogeneity. This is their forest plot, so the top cluster are supposedly their high quality studies, and then the rest are just the observational before and after studies. Again, you can see that a lot of the benefit or what's driving the relative risk to be less than 1 comes from the observational before and after studies, and the higher quality studies are a little bit closer to that relative risk of 1. In the discussion, they comment on how there was striking variation with how the rapid response systems were constituted, delivered, and evaluated. There was a high degree of study heterogeneity, more so from these before and after studies without a contemporaneous control. And then I thought this was an interesting endpoint they'd looked at, that physicians were present in 65 of these studies, and they found that it doesn't actually change outcome to have a physician at these rapid responses, potentially because a lot of the interventions that are being done don't necessarily need a physician to order it. It's just, IV fluids or Lasix, Narcan, things that a physician doesn't necessarily need to be present for. And they were unable to show a significant relationship between the rate of RET activation and hospital mortality, which would suggest that mortality benefit is not through reductions in cardiac arrests. So at first I was like, maybe this myth is plausible. The relative risk was 0.91, but then I started looking at this data again because it didn't quite make sense to me. Only 13.9% of the data actually came from high-quality studies, and they didn't weigh it any higher than these observational studies that have significant heterogeneity. Even with these high-quality studies, the relative risk is 0.91, which isn't that strong, I think, of a relative risk. And then it must have been late at night, I started comparing meta-analyses. And if you look at the Annals meta-analysis, the relative risk they got for the Hillman paper, which is that RCT I already talked about, they had calculated a relative risk of 1, whereas this critical care paper had calculated a relative risk of 0.83. And I dove into their statistics section and tried to figure out how they came up with this number, and I was really unable to. They have an equation that they used to account for the heterogeneity. I talked to her statistician, and she wasn't quite sure either. But I think when I took a step back, something about it didn't quite make sense, that there would be that much variability in a result. So then I started looking at the actual studies themselves. That were considered to be high-quality studies. This first one, Bristol et al., published in the year 2000, it was actually a prospective cohort, and it looked at a total of 3 hospitals, but there was no randomization. 1 hospital got a rapid response team, the other 2 did not. And they even did a case mix at the end to account for the variability in between individual patients. And their conclusion was actually that there was no significant difference in total mortality. The Howell et al. Study in 2012, this was an interrupted time series. I think they considered it to be higher evidence because it included a larger amount of patients, but there wasn't a contemporaneous control. And in the end, it didn't show a significant change in overall mortality. The Priestley study, 2004, was a step-wide cluster RCT. And what they did is, this is, I think, probably the most interesting design I read about, is they had 1 hospital and they implemented rapid response teams to different wards of the hospital, kind of in an increasing manner, so there was no blinding possible. And they're the only study that did show significant reduction in mortality. And then we already discussed the Hillman study, which in my opinion is really the only high quality study that I could find. It was a cluster RCT, and they found no effect on unexpected death. The other thing that's missing from the literature, there are no cost-benefit analyses of rapid response teams. So I just thought of a couple points for both. Cost, there's a high cost of education and implementation. Significant hospital staff are involved in these rapid responses. And then there's also an effect to ICU patient care because the nurses that go to rapid response teams actually have to sometimes leave their patient to go respond to these. The benefits are that rapid response teams start DNR discussions. I think we as residents, that's one big thing we can do when when we go to rapid response teams is to discuss, would it be appropriate to resuscitate this patient? And that in itself can be cost minimizing because it reduces the amount of patients that have to get transferred to the ICU. And then sometimes we can catch complications before it leads to further and more serious complications, which could lead to longer hospital stays. And then just a little bit of our data from Cottage Hospital. A lot of the literature looks at rapid response call rate in a rate of 1,000 admissions. So this is a very crude estimate, but we have about 3.5 calls per 1,000 admissions, and this data is from 4 months since the beginning of this year. The merit recommendations are typically a call rate from 20 to 40 calls per 1,000 admissions, but what was interesting was in their randomized controlled trial, they only had a call rate of about 8.7 per 1,000 admissions, and they had actually postulated that having more calls might lead to a bigger change in mortality, but there have been further studies that showed that increasing call rate does not decrease mortality. There's no association. And then just for those who are curious, our average rapid response call rate, just the gross number is 27.7. The average amount that are transferred to the ICU is 47%, and the amount of patients that survive to discharge is 77%. So for us as residents, should we go to that rapid response? This is the actual, I copied this from the policy, the actual recommendations for residents. We are not required to go to these rapid response teams, but we are required to answer our pages. So nurses have to page a resident before they call the rapid response team, and if the resident doesn't get back to them within 5 minutes, they will call a rapid response. So the first thing I took away from all this is we need to be answering our pages. The second point is if this is your patient, you should 100% be there. There's a change in your patient status. You need to know what that is. You need to go. If you're on call and it's on the resident service, I would recommend at least swinging by, especially if it's later in the day because the primary team might have left for the day. Otherwise, I would say use your clinical judgment. If you are currently doing something that directly affects the mortality of your patient, I would continue to do that. I wouldn't go to the rapid response. If you're sitting down in the middle of the afternoon and just working on progress notes, it might be a good idea to go to the rapid response because it truly is a cry for help, and nursing is struggling, and so you can always go and help them out. So my conclusion from all of this is that there's really only one true RCT that exists, and it really showed no effect on in-hospital mortality with rapid response implementation. There are no cost-benefit analysis. Physician attendance does not change mortality, but I'm not anti-rapid response team. I also want to mention that. I think there are a lot of benefits of rapid response teams. We just have to be clear on what those are. Rapid response teams greatly improve communication. They educate nursing staff on what these warning signs are, and they can help avoid ICU transfers by people transitioning to comfort care or just to a DNR status. Ultimately, though, despite ethical and implementation difficulties, we just need more data. We need more high-quality RCTs. And that's my conclusion. Questions? Yes, Clay.
How logistically do they do the contemporaneous studies? Do some patients get a rapid response at the same hospital and other patients?
It's such a good question, and that's the big issue with trying to test this topic. And the only way that they can really do it is with cluster studies that look at groups of populations, which is why the only real study we have is through hospitals, just looking at clusters of different hospitals, because otherwise ethically it doesn't quite make sense, which is why I thought that Priestley study was interesting because they did that. They did it by wards, so some patients a rapid response wouldn't be called on them. So it does make, I do acknowledge that the design is very complicated to test this. Oh, these are my references.
All right, so getting back to our myth or potential myth, rapid response teams improve in-hospital mortality rates. So how many people feel that this is true, that there's a lot of evidence that rapid response teams improve in-hospital mortality rates? How many feel it's plausible? A few. Mm-hmm. How many feel that it's not, that it's busted? All right, well.
And quick comment, I do think, I struggled with this because I do think it could be plausible, but I just feel like there's really insufficient data. Dr. Freed told me to just go with what I felt, even but I was like, I think it could be plausible.
So you're voting for plausible?
I'm in between. I'm like, if there's a way between plausible and busted, I just feel like we have insufficient data.
I think that, you know, the best data that we have shows that it probably doesn't. But again, we probably don't have enough data. So, but we're going to say it's busted because, should we say it's busted?
It's busted for the video.
Yes? No?
There was majority. Majority said busted.
All right.